Welcome to the TechPulse Healthcare Podcast. This is episode 11, and we have our guest Kez Spelman with us. My name is Atif. I run the company Immersive Horizons, focusing on scaling and XR implementations across industry. With me is my co-presenter, Jonathan Probets. Hi, Jonathan.
Yeah, hi everybody. Hi Atif. Hi Kez. I'm based down in Torbay in South Devon in the southwest of the UK. I'm a nurse by trade, and I look after the preceptorship program here down in Torbay, which is helping newly qualified professionals come into professional practice. So great to be here. Thank
you. So Kez Spelman serves as the Director of Innovation and Community Resilience at Provide Community, an award-winning employee-owned community interest company. And you can tell us what both of those things are, what your company does and what a community interest company is. The Director of Innovation. Before you do that, I was quite interested to know innovation and the NHS. So I was speaking, in fact, just to Jonathan last week around the cuts and the strain on the NHS and the lack of budgets and things like that. So you'd think innovation was probably the last thing on their mind, or the first thing to go when they're looking at cuts. Yet here you are as Director of Innovation, trying to spread that love across the healthcare industry. So how does that work?
I think it's almost like a little bit not quite a double-edged sword, but innovation. We're in a position now where I can't remember and I've been a nurse for a lot of years. I've been around in the NHS and in public service for a long time, and I've never known the pressures, the expectation, the demand be at this level before. And I think there's something about those pressures that are really forcing us to look at new ways of working. And I think that's not just from a point of view of planning and strategy. That's from the point of view of actually frontline delivery. And I think coupled with that are people's development around development in using technology, but also understanding technology. And I think in the past, perhaps there's been assumptions made about people delivering frontline clinical services that have been perhaps about, tech for another job, for another part of the business. I think now people are understanding that it's probably one of our main sources of being able to deliver on this demand that we've got without capacity growing.
Sure. So can you tell us a little bit about Provide Community and just about what it means to be a community interest company?
Yeah, I suppose what's key about a community interest company is that we aren't a direct part of the NHS. However, we deliver NHS services, but along with delivering NHS services through ICB contracts, we've also got local authority services. We've also got elements of other contracts, and we do private delivery as well. And I think there's something about that mixed bag of delivery, which can sometimes get a bit contradictory, but it does make for a level of opportunity, I'd say, especially around testing new ways of working. I think what's important about a community interest company that's member owned as well is that ultimately we're accountable to our members. So that puts an emphasis on our delivery that perhaps isn't there in some more traditional public service service ethos. It's probably not there so much, because ultimately, we've got to do a job of work in public service. But the difference between a community interest company and a more traditional NHS service is community interest companies have to balance the books. And I'm not suggesting that traditional NHS services don't have to balance the books, but the implications are very different for those two organisations.
So that's a really interesting point, Kez. If I can just ask Atif at this point then, so what are the implications then? If you don't balance the books?
We close.
Right.
We close and staff TUPE. And, you know, the services will get transferred. And, you know, we have seen, it's unfortunate, I think we've been a community interest company now since 2012. I joined the organisation when it was part of the PCT of all things. Then it span out of the NHS in 2012, become Central Essex Community Services, and then became Provide after that, because ultimately, as a community interest company, we didn't want to just be about Essex, even though that's where a lot of our work is. It was about really recognising the opportunity to go beyond traditional geographical boundaries. But what I was going to say, there was a lot of groups that span out of the NHS at that time, and it is really quite. And over the last 12 years, 10 years, we have seen groups, certain health and care CICs fold ultimately, and those staff TUPE over to local community trusts, local community foundation trust, other hospital foundation trusts. So that is the thing. So you could say that actually, given these times of very, very tight budgets in healthcare, you know, there's a risk there. But what I would always say is the opportunity around community interest companies in healthcare is their flexibility and their speed. They're certainly not as huge as some of the big foundation trusts, but there's an element of agility there, and which really gives innovation a good test bed.
Yeah, I think innovation and agility kind of go hand in hand, right? If it doesn't really work if you can't do that. Yeah. Excellent. So when we look at innovation, I know you've been involved in a few things, and I do want you to tell me. But if we look at RealWear, for example, as something, kind of what's the what would you say is you know, what problems are you trying to solve with RealWear? Sorry.
I think the main one part for me, and speaking as a clinician, is that there's a lot to do across a large area and not enough people to do it. What can audiovisual tech enable in terms of that support? And we all know, ideally, you have more people around, you've got more people with skills to deliver care. But when that isn't possible, what can you do to create the next best thing of having another person there, another person supporting, another person with you? And that's something about audiovisual communications technology that effectively allows a delegation of tasks and a support for skills development that's virtual. So people would wear a headset, they would be going to work with somebody in their home or another part of the community, and there'd be a central point of expertise that could guide that person. And we've worked that in both ways. It's been successful in a number of scenarios, but the biggest challenge I think we've had has been twofold. There's been a connectivity thing that people are very conscious of and is real, and it's got to be fixed. So that's something about, I think it's something about an infrastructure issue that probably is national rather than local. The other thing is, this sounds silly, but it's about putting something on your head. Wearables, they sound great, but people choose what they wear, understandably. So that whole point of introducing something like this that you have to wear in order to bring somebody virtually into your clinical examination is still quite a step. So as much as we've perhaps not got the adoption we'd expected, we've got some really good, interesting use cases, both in terms of delegating care safely. We've also got some really interesting cases of how we've supported training through the use of these devices. But for me, the future is about making wearable tech like this, like these spectacles. So and I don't think we're going to be far from that.
I don't think we are even now. Maybe. I mean, I haven't seen one of those RealWear things for a while. Those are kind of.
Well, this is the updated version.
It reminds me of one of those Star Trek Borg things that they used to do. I think, and it gives you a real headache if you do use them for a while. So they're up there. They certainly. I think things have moved on the actual headset situation. But yeah, you're right. You know, I was just thinking that when you put your own glasses back on, that's really what you want, isn't it?
Exactly. And as much as this has got some sort of function, we've got to get the form to match the function. And my money is on how regular spectacles will become that audiovisual support. Not only that, it'll be a recording of the whole clinical conversation, which is something that's very topical at the moment, and we're looking at, which is that whole ambient voice technology opportunity.
So Kez, I guess that this technology that we're talking about now, whether it's the RealWear or whether you end up going to adopting something from the future that, like you say, is more wearable and involves the ambient technology, that for a CIC is going to enable you to potentially reduce costs, but I guess more importantly for you, it's going to enable you to bring that expertise into the room from elsewhere and improve patient care.
Absolutely. And I suppose what would be a vision for me, and I was trying to keep to that end vision, is you could almost have networks of care that support this, so there's not to say that through a network structure of experts having access to people wearing audiovisual systems contained glasses, being able to deliver really effective and safe care in a delegated way. At the end of the day, this is all about delegated tasks, delegated clinical tasks, and it's a tough area. Clinicians are rightly proud of what they do. Clinicians are understandably concerned about dangers in delegation, and as our patients, as our families, it's all understandable. But there's something about the demand we've got, the capacity we've got, and trying to understand where we can safely delegate. And I think this sort of technology is part of is one part of that.
Yeah. And it's interesting you mentioned that, because I mean, like, my son was ill recently. I took him to hospital, and then on the journey going to the GP and everyone, now we ask the question, are you an actual GP? Because sometimes because they've delegated these things down to others who you hear these stories, even the hospital. Now I'm asking, can you just? It's really awkward, but are you a consultant? What who am I talking to? I just want to know who I'm talking to. And it's interesting, but with the RealWear, I guess. I mean, how are you actually using? Is it connecting? How does it work? If you step through, like, we go into someone's house.
It's basically the simplest way to describe it. It's a mobile phone that's been configured to sit on your head, to have a little screen that you can see through glancing down, or glancing at using this more this smaller version through this little portal here. That's your screen of your phone. The difference it being is it hasn't got a touch screen because it's voice activated. So basically you talk to it and ask it to join Teams call, click, call item 1, click, and it will take you through to, ultimately it's a pretty agnostic device, and that was what was quite good. Few things we wanted out of a device that was a wearable. We wanted to be system agnostic, so we could use it. We have some choice in terms of what we used, and we weren't linked to a license like a meta configuration. We wanted to be assured about our data, and we wanted it to be robust. That's why we went with RealWear, because ultimately it's got a 2 meter drop test and it won't break, and it was designed for industry. So so where we are at the moment is that our most recent exploration was around rather than giving the RealWear to nurses, we gave them we had an issue whereby nurses were saying we're getting lots of call outs for relatively minor things that could be supported by virtually quite easily. So skin tears, knocks, bumps, things like that. And then that was expanded out to look at catheter positioning. So it wasn't catheter care, it was around catheter positioning, because so it was really there to try and understand how we can avoid unnecessary call outs.
I can really resonate that really resonates with me, Kez, having done a lot of kind of out of hours and district nursing activities, and yeah, when you've got a large geographical patch to cover and you've got calls coming in at all times of the day, there are so many things that could be fixed locally without a visit if you could just see what was going on and ask the right questions. So let's go forward a little bit. Let's imagine then we've got kind of, you know, a Ray-Ban style, or let's say, you know, just regular glasses.
Yeah.
Given that some of your teams have been through this adoption life cycle and probably that you know that they've done something really difficult, something that many organizations don't manage to do. How, to what extent do you think that's prepared them for when the technology becomes a little bit less intrusive and more normal? How do you think they're going to cope with say, you know, generation two?
I think there is inevitably there's going to be some people that don't like the idea of delegated technology supporting delegated care. There's some people that don't like the idea of delegated care. There's still some people that don't like the idea of nurses managing clinical care. There's some people who don't like support workers taking blood, for example. So I think there's always going to be that element. But my view is that the more exposure to the tech-supported delegation will enable a level of adoption that's going to be more rapid when it comes to a more comfortable form. And I'm pretty clear about that. And plus, I think we've got to understand that generationally, people will be moving on with their own probably personal purchases around technology, which will then align a lot more to perhaps some of these developments that will come about in healthcare delivery.
Right.
Have you found, is there, both from patients' resistance and from, because what people, you know, especially with the AI world we're living in, people worry about, oh, you know, if you start doing this, and you know, it means less jobs for everyone else and all this sort of thing, and these things are taking over. Have you experienced any of that?
Certainly, I think, I understand that. I think from the point of view of patients and this technology, we were led to believe by some people that there'd be a bit of a backlash, and that wasn't apparent. So it felt that. So and we did consult with people in terms of a range of patients around their use. That whole, I suppose the difficulty is that with any innovation like this requires investment. And quite often that investment isn't a single investment, it's a recurrent level of investment, whether it's about license fees that are recurrent. And so we've always got to have that difficult consideration about where the money comes from, where often the money comes from is through posts. However, I think part of the answer to that is when you've got services that are so overburdened with demand, it's unrealistic to look at actually shifting pay. It's more about how we use this technology to work with what we've got and free up other people to deal with that level of complexity that is increasing, I'd suggest. And that might be to do with expectation, that might be to do with new treatments, that might be to do with new diagnoses. Things are complicated.
Yeah, I guess in the NHS, compared to other industries, maybe in the IT and other places, there will genuinely be, I think with some of these new technologies we see, there will be jobs that are no longer there and things like that. I think with the NHS, maybe it's a bit different in that the demand is so much more than the supply, and it looks like, and it's only going in that direction further and further, that, yeah, like you say, it just frees up more people rather than...
Atif, I was going to add that there's still something about the bureaucracy that runs the NHS that it's right for automation. And that's another area. And I'm not going to put myself apart as a clinician as opposed to an administrator, because, you know, the clinical services couldn't run without the backup services that are in the background. However, there is probably something a little bit more straightforward about some of the automation opportunities and tech applications in those areas with robotic process automation, etc. That again is going to be about releasing staff in some way, shape, or form. But again, I think with technology, that's not going to be just an NHS issue. That's going to be the whole labour market, I'd suggest.
Right. Okay. I saw. I know we've focused a lot on RealWear, and maybe we're kind of XR AI focused here, but I did see a video of yours on, I think it was on LinkedIn, where I think it was some technology helping you walk, or helping to help people walk. And obviously, you're involved in other innovations that maybe we won't have time to cover. But if you were to just think about one or how many, or just a key time when you are amazed by a reaction to your innovation, or something really that you didn't expect, or from someone using your innovation. Can you think of anything kind of like that? And I know I'm putting you on the spot.
Yeah, I think it's probably going to be going back to the audiovisual support, the RealWear. I think one of the times that really was impactful for me was seeing a group of people who used RealWear to support their skills deficit. It was a bunch of podiatrists that were short-staffed, could recruit newly qualified podiatrists, but the newly qualified podiatrists didn't necessarily have the skills to deal with the complexity of the people that had issues with their feet. So they used the RealWear, gave them to the newly qualified people, and basically doubled their throughput of people instantly. Wow. And that was a real shock. It was a shock to me, but it wasn't what we were expecting people to use them with. But it was almost the ingenuity of that team, considering the technology and making it work for them.
Wow. Well, thanks for sharing. One last question for you then. Just what does the future hold on the innovation front? Or I know you might not be able to share everything. Or what do you think is going on in the next 5 years, generally, or even with you guys? Yeah,
I think what's going, things that are very tough in terms of new business. There may be opportunities to build in new technologies, but I think for existing ones, it's very difficult to build in new technologies. And sometimes, I talk about adoption. Sometimes the adoption is almost impossible because of the absence of any investment. So you can get to a point where you can prove a case, but if there's no investment, there's no investment, which is going to be very tough on people. I think what I'm particularly excited about is the whole idea of how AI is going to be used to move us on from data retrieval that is so labor intensive to data retrieval, which is spot on, pinpointed, relevant, and ultimately accurate. And I'm particularly excited in that, and how we configure that ability, not necessarily by buying products off the shelf or systems that people have sort of used a generic AI setup and then sold you something. It's about how we're going to be configuring these services and systems. I think one thing that I will add at the end, there's something quite exciting about Agentic AI and how that's going to support developments. So really, ultimately, that point in the future whereby there's going to be a level of autonomy around some of this technology, which is going to be scary, which is going to be, we're going to have definite, I call them guardrails and everything else, but there's got to be some definite, security around that. But I'm an optimist in some of these things. You can read all sorts of dystopian sci-fi. I read the optimistic stuff and I read the dystopian stuff, but the optimistic stuff is, I think there's some real opportunities there. What I will say, just as a closing point, though, it never ceased. I went to a quantum conference, and it never ceased to amaze me how the focus for all tech is generally about guns and weapons, first of all, and defence. Than it is, and then about finance and making sure the banks aren't robbed, and healthcare's way down on the list. And I always find that a real sad. I don't know. I always find that a concerning reflection of humanity, that priority. And I'd love the future to where that priority was reversed. But that's me just probably being naive or optimistic and naive. I don't know.
Yeah.
Well, when you sorted that out, Kez, can you let us know? Yeah, I'll get out of bed for that.
I dare say that's what we're trying to do here with this podcast as well.
Yeah, right.
Small effort, a penny in the in it all, right? So but yeah, we can only try and steer things are right. But thanks very much for your time, Kez. It's been really interesting to hear. I know it's just almost a sound bite that we have here, but people can learn more about you on their LinkedIn page and on their website as well. So, but yeah, thanks for taking the time. Really appreciate it.
Nice to meet you, Atif, and nice to see you, Jonathan.